Right, hello everyone, and welcome to this session of the Health and Care Analytics Conference 2025. My name is David Callaghan from the Strategy Unit, and I'm going to be your chair for this session, where we've got a series of excellent presentations around improving flow. We want to get straight into it, make the best use of the time, but a few quick housekeeping points. I'm sure you're familiar with these by now. Please use the Q&A box to submit questions at any time. You can upvote questions you're most interested in, and I'll pick those up first for the speaker. The chat is open for reflections and discussion. You can view speaker bios and connect with speakers in the People tab, and you can take notes directly within the platform as well. So that's the admin done. So without further ado, we will begin now with the first presentation that's going to be delivered by Marcus Yarwood, who is Senior Quantitative Insights Manager from Imperial College Health Partners. And he's going to be delivering a talk around understanding NHS waiting lists, insights from the Networked Data Lab in North West London. So over to you, Marcus.
Great, thanks so much. Thanks for the intro. As David just said, I'm Marcus and I work for Imperial College Health Partners, ICHP, which is the health innovation network for Northwest London. And I'm presenting today on a project that was done in collaboration with the Health Foundation called the Network Data Lab. And this was the topic that we did. The most recent topic that we did was on waiting lists. You might have also noticed there is another Network Data Lab presentation happening later this afternoon. That's a presentation by the Health Foundation. So I'd definitely urge you to kind of go along to that one as well to see their view on things. If I try and move my slides across, there we go. So what is the Network Data Lab? So as I say, it's a collaboration with the Health Foundation, and it brings together analytical teams across the country. So we are one of 5 labs across the country, and there were four of those labs worked on this topic of understanding waiting lists. And the ultimate aim is to kind of have a deeper understanding of the factors affecting people's health, and a different topic is kind of picked each year. So the kind of insights from this are then shared both locally and nationally, and they kind of then provide evidence for kind of some policy areas or improvement areas. So as I say, the Health Foundation has commissioned this program, and the Northwest London lab is made up of Imperial College Health Partners, which I represent, as well as Imperial College London and the ICS in Northwest London. A big part of this analysis is a collaboration with a kind of patient and carer advisory group. So PPIE, patient public involvement and engagement, is really, really strong in this project. And at every stage, we try to engage patient and public partners as much as possible. So that includes the kind of scoping element of each topic. The patients and public will have involvement in what research questions we investigate. They're able to have an opportunity to kind of express their views on where the analysis should go. We then present kind of decisions on research questions, share kind of highlights from any statistical analysis plan. And then kind of share interim results to kind of get their kind of insights and views on some of the results that kind of feed into the final report. So here's a kind of example of the kind of the flyer that was shared in recruitment of people on that advisory group. The dataset that we use for this analysis is called the Discover dataset, and that's kind of a kind of requisite for the being one of these labs is having this kind of linked data set that we're able to link across healthcare settings. So the Discover dataset contains patients who are registered to a GP practice in North West London. So that's currently around 2.9 million patients, but it also includes patients who have been previously registered. So that's an additional 2 million patients who we have their historical data for. So as I say, it's linked across multiple health settings. So that's across primary care, so primary care observations, prescriptions and appointments, as well as secondary care in the form of SUS, so accident emergency, inpatient and outpatients, as well as some community, mental health, social care data, as well as, of course, waiting list information, as well as some kind of bespoke data sets in there as well. Access to this is managed by a data access committee who meet every month, and they assess every project based on its benefits to public. So you've got to demonstrate some benefits to public benefits in order to have access to this data. And yeah, it's a de-identified data set. So there is a identifiable kind of clinician-facing version of this data set, but for kind of research purposes and kind of also service evaluations, there is a de-identified version which we access for this. Because it's de-identified, there's no kind of patient identifiable data in there, but it does mean that there is a patient key for which we're able to link across all of these health settings. So be able to see a patient's journey across like primary care, secondary care, and across community mental health, etc. So really, really, really powerful. Onto research objectives for this analysis in particular. So objective 1 was around describing wait lengths for patients waiting for elective care. 2 was around describing the reasons they're removed from the waiting list. And then objective 3, looking at the primary and secondary care healthcare usage before and after waiting. And then objective 4 was more of a causal question, assessing the impact of waiting for longer periods of time on healthcare usage and costs. So these were derived in collaboration with the Health Foundation across. So all labs across the country looked at these same research questions. So onto some of the results. So here we've got a kind of proportion of patients waiting less than 18 weeks and within other kind of categories of waiting time by age group. Now here we see that 73% of people aged 85 plus waited less than 18 weeks, whereas 63% of people aged 18 to 24 waited less than 18 weeks. So some kind of age disparity there. Where younger people generally seem to be waiting longer and lower proportions of them within the kind of 18 weeks band. However, when we looked at a lot of other demographics, we were kind of struggling to find differences between these proportions. So, for example, this is looking at deprivation quintile, we struggle to find any kind of major differences on waiting times. And this was kind of consistent across a lot of other kind of demographic variables. Looking at the kind of frequency of the waiting list, we can see a kind of a heavily tailed distribution here. So big proportions of people within that kind of shorter waiting time, but then it kind of the tail kind of carries on a long time. So you've got some patients there who are waiting multiple years within that for their treatment. So this means that when we're kind of looking at the standard deviation and mean, it will be much more sensitive to outliers. Therefore, median might be a more appropriate to be looked at. So that's what we did. We looked at median wait times, and it gave a slightly different perspective than looking at just like the proportions of patients, proportions of pathways within 18 weeks, which is kind of the traditional way of looking at things. So we found a difference between genders, so a slightly men's waiting slightly longer than women on the median wait time, and then by ethnicity, some slight differences there, where white patients generally have a shorter median wait time than other ethnicities. And then age band, as we saw in the kind of other chart, we're kind of seeing big differences there between the younger age groups and the older age groups, where older age groups generally or their median wait time is much shorter. And then for those other demographic variables where we kind of struggle to see differences in proportion waiting in 18 weeks, we do start to see some differences here. So those most deprived, although the differences may be smaller than you might expect, there is some differences there where the most deprived are waiting slightly longer on average for the median. And we also looked at frailty here, so some slight differences there, whereas maybe those more severe frailty patients are kind of being prioritised. It's worth noting that when we showed this to the patient and advisory group, they kind of expressed a little bit of concern at these results and the fact that might not kind of reflect some of their lived experience, and they were kind of maybe surprised at the kind of lack of differences that we were seeing here. The biggest difference we did see was across specialties. So neurosurgery, neurology at the top there in terms of the highest wait length on average. And then down at the bottom, you've got some of the kind of, I guess, things like elderly medicine, mental health, things like that. So that was the biggest difference we saw was between those specialties, which might, have an impact on some of the differentials in demographics as well. This is one kind of outlining some of the gaps in data quality that we had. So when we looked at kind of reasons for removal, there were big gaps in data quality. So, over 40% of pathways we weren't able to find the reason for clock stop, which means it's very difficult to analyze that further, right? When you've got a high level of missingness, there's not really much you can do with that analysis. Looking at healthcare usage, there were slightly, maybe slightly surprising results here in that for most healthcare settings, we were seeing a higher rate of usage prior to their referral compared to whilst they were waiting and after treatment. And that were except for the elective admissions, that is. And it's most noticeable for those A&E attendances where they kind of got quite high rates of activity prior to referral. When we looked at costs, obviously that kind of tracks very similarly, so you can kind of see very similar trends for A&E attendances, emergency admissions, and GP appointments. But for the elective admissions, slightly different. We're seeing a kind of higher cost of elective admissions whilst they were waiting, and a decrease in cost after treatment as well. So just in the last kind of minute or so, I'm just going to kind of our last objective was looking at the kind of the causal element of longer waits. And this was our method. So we were looking at a staggered difference in difference analysis. Now, this is a kind of example of what we were expecting to see. And we were expecting to see a kind of steady rise in activity, like whilst people were waiting. And for those longer waiters, we were kind of expecting a kind of higher rate of healthcare usage during their waiting period, and immediately after their waiting period. And then once they're treated, a kind of steady decline in healthcare usage. As we've seen in the previous slides, that wasn't really the case, which meant that doing this cause analysis was quite tricky because those assumptions that we were making on the methodology weren't met. So some interesting findings, and we still went ahead with this difference in difference, and kind of again struggled with some of the data quality elements, which meant that we were having a high levels of exclusions, which meant that significance wasn't met on a lot of our findings, which was unfortunate. But I guess a finding in itself in terms of advocating for better quality of data in order to be able to do this kind of analysis. So one final slide on implications and impact, and I realise I'm slightly going over, but I'll just go through quickly. So as I say, some groups waited longer, but disparities varied mostly by specialty, and those kind of demographic variances weren't quite as high as maybe expected according to the patient advisory group. Again, healthcare usage patterns weren't as expected, which limited our causal analysis. As I mentioned, kind of there were significant data gaps and difficulty linking the waiting list data to secondary care in order to get that kind of that link to kind of healthcare usage and to the actual procedure that was carried out, which made it difficult to get to those conclusions. insights from the patient advisory group were really, really valuable. They kind of talked about the impact on physical, mental, and economic well-being, where lots of people turning to private care. And they also identified gaps in support and communication. So lots of need for communication whilst people are waiting, to inform where they are on the waiting list, ensure they haven't been forgotten about, essentially, and promoting that kind of waiting well element. So thank you all for listening. Hopefully there's maybe a time for at least one question, but I realise that I might have gone slightly over my time limit. But thank you so much.
Sorry, that's quite all right, Marcus. Can you hear me okay? We've just got a couple of minutes. Someone asked about whether the differences you saw were statistically significant. Can you say anything about that?
Yeah, so, most of those descriptive elements we were purely descriptive. So the answer is no on a lot of those. The kind of causal analysis, we did find some a statistical significance in terms of the GP appointments, but it was kind of in the opposite direction to how we'd expect. So it's kind of then quite difficult to interpret, in the fact that we found an increase in GP appointments following treatment. So, that maybe the kind of hypothesis that we had maybe needs to be altered, and then the methods altered in order to kind of get that cause analysis correct. But definitely some learnings in terms of how we derive that methodology.
Okay. And just one last thing. I mean, were any of the results, more unexpected than others? Were there any real surprises in the results? And could you share your thoughts on those?
Yeah, as I say, there were lots of kind of, when we presented these to the patient advisory group, I think that's a kind of key learning from this study was the engagement with the patient and public in terms of interpreting results. A lot of them kind of expressed surprise at the lack of difference in waiting times between some of the demographic groups that we're looking at. That a lot of their lived experience was that maybe the older age groups were kind of being left behind or being forgotten about, or there were kind of huge disparities between socioeconomic groups, which we found, I guess, some evidence of, but there were very, very small differences. And obviously, the kind of patterns in healthcare usage, which we had made assumptions about in terms of our cause analysis, meant that were surprising in the fact that it meant that the methods were no longer viable. So, yeah, maybe there's something about a kind of staged approach in terms of assessing the methodology for a causal approach based on some of the descriptive results, which is something to take on board.
Brilliant. Okay. We're just having a slight difficulty with the next speaker, so which means that we've got time for one more question, Marcus, if that's all right with you. So,
all right, yeah, perfect.
The final one was, what program did you use to analyze the data? Was it R or something else?
Yeah, it's a combination. So all of our data is held within Snowflake databases. So it's it's a combination of SQL to extract the data, and then we used R for a lot of the analysis. So a lot of those data visualizations, as well as the putting together the causal elements. There is we have put all of our kind of code on GitHub as well. So I'm happy to kind of share that as well.
Brilliant. Well, thank you so much for a brilliant talk, Marcus. That's all we've got time for now. So I'll let you go, and we'll bring in the next speaker. Thank you very much, Marcus.
Great.